All right, now we're going to talk about hematologic disorders. So again, you can review that nursing process overview for a child with hematologic disorders. The anatomy and physiology of the hematopoietic system, blood formation and components, that should not be new information for you. You can review that. Assessment of and therapeutic techniques for hematologic disorders, and then health promotion and risk management, you can review that as well. We're going to start talking about your first disorder. And that will be on the next slide, and that's iron deficiency anemia. On this slide, this little chart with all the different signs and symptoms, that comes straight from your book. It's kind of an overview, regardless of what the specific disorder is, some things that you can see symptom-wise or complaints that they have with hematologic disorders. We'll get more specific once we get into the particular disorders we're going to talk about. Let's talk about iron deficiency anemia, our first topic. It is the most common anemia that we see of infancy and childhood, and it's basically an intake of dietary iron is inadequate, just what it suggests. We have deficiency. So without adequate iron, hemoglobin can't be incorporated into our red blood cells. Children who are at higher risk for iron deficiency anemia, they need more daily iron in proportion to their body weight to maintain an adequate iron level. Daily intake should be 11 to 15 milligrams of iron. So why do we see, especially in infancy and childhood, there's certain age groups that we tend to see iron deficiency anemia in more frequently than others? It occurs most frequently between ages 9 months and 3 years, and then again in adolescence. Well, why between 9 months and 3 years do we see it? Then there's a big break until we hit adolescence. Well, in infants are drinking more milk than they are eating iron-rich foods. That could be formula, that could be breast milk, and even as we transition to whole milk, they're drinking more milk than they are eating the iron-rich foods. And for adolescents, the reason we see it is because go back to their growth and development. What is their nutrition like? They hit those growth spurts. Their iron requirements increase in order to meet the nutritional demands that their body needs. And especially for girls, when they start menstruating, are going to need more iron. Excuse me. For the infant, the newborn usually has enough iron reserves to last for the first 6 months of life. And after that, then they need iron incorporated into their diet. Well, when you think back to growth and development, when we talked about growth and development, when do they start with solid food intake? They usually start between 4 and 6 months. That's because at 4 to 6 months, their iron stores are starting to get a little bit lower. It lasts for those first 6 months, and then as those iron stores start to deplete, we're starting to incorporate iron into our diet to combat that loss of the iron reserves. Also, if you think about infants who are born with structural defects of the GI system, they're particularly more prone to iron deficiency anemia because iron cannot be adequately digested. So those who have the gastroesophageal reflux or pyloric stenosis, basically they're not absorbing enough, because if they're constantly refluxing or with pyloric stenosis, they have a lot of vomiting, then they're not adequately digesting what they need. Infants who have chronic diarrhea also have inadequate absorption. And it's important to think about, why do we give breast milk or iron fortified formula rather than cow's milk for an infant? And that's because cow's milk does not have a good supply of iron, as well as it is irritating to the gastrointestinal system, because think about the infant, they're not fully developed. That GI system isn't fully developed. So if they're fed cow's milk rather than breast milk or an iron fortified formula, it can cause a lot of gastrointestinal bleeding because it's irritating to their GI system. And then because of the bleeding, you get into iron deficiency anemia. So our preventative measure, you always urge parents to breastfeed or use an iron fortified formula, as well as introduce cereal as the first food, are important to prevent anemia. And occasionally infants who are bottle fed with iron fortified formula can become constipated because of the iron. Well, then we just do measures to combat the constipation. We don't get rid of the iron fortified formula. When we think about older children and why they have iron deficiency anemia, children who are over the age of 2, usually it's because of a chronic blood loss is the most frequent cause for iron deficiency anemia. And again, it's caused by gastrointestinal tract lesions, and you can see those there. And I already mentioned, especially with the adolescent girl, as she starts menstruating, having her period, then we see them become more iron deficient. As well as you have to think about the adolescent in general. Yeah, they hit that growth spurt, they have a greater need for iron, but the other issue is what's their diet like? They're not always grabbing the best items to snack on. So in combination with just the puberty that's hitting in those growth spurts, as well as sometimes they're not especially if it's, you could say even guys too, not just girls, if they're attempting to diet, then again, we're not getting the iron in their diet like they should be. When you think about the assessment and the signs and symptoms associated with iron deficiency anemia, assessment-wise, you need to be doing a 24-hour dietary history, and especially in infants, we want to find out how much milk are they drinking per day. An infant should not ingest any more than 32 ounces of milk per day, because if they're filling up on milk, then they're not not taking their solid food intake, and then they're too full on the milk and not eating the solid food that could contain the iron that they need. And we know that milk is not a good source of iron. Common symptoms that we see in iron deficiency anemia, we can see pale conjunctiva, we can see paler in general, poor muscle tone, especially in infants, poor muscle tone. The heart can be enlarged, the spleen may be slightly enlarged. Their fingernails are typically spoon-shaped or depressed in contour, so clubbing of the fingernails. And again, why would we see clubbing of the fingernails? Well, if we don't have enough iron in our diet, iron is important for red blood cells. If the red blood cells aren't getting what they need, then it affects our oxygen transportation in the body. Hence why we get into clubbing of fingernails. And again, as a general rule, I already mentioned this earlier, infants should not ingest more than 32 ounces of milk per day. In the school-age child, we can see an association between iron deficiency anemia and poor school performance or achievement, usually because they're too tired. They're not getting enough. So they're falling asleep in school, they can't focus and concentrate, and you'll see oftentimes their grades are going down. We can also see what's called pica, which is they're eating things that aren't typically edible. They usually have particularly a craving for ice cubes, and sometimes the inedible sources like dirt and paper. And when they're eating those kind of things, that's called pica. When you think about diagnostics for iron deficiency anemia, overall, they're going to have a decreased hemoglobin level, and they're going to have a decreased hematocrit level. We'll also look at their RBC indices, and it will show decreased as well, and their serum iron levels are going to be low. So everything is decreased because they don't have enough iron in their diet. All right, our therapeutic management and nursing care for iron deficiency anemia. Ideally, we want to treat the underlying cause, the lack of iron. One of the main ways that we do treat iron deficiency anemia is by giving an iron compound like ferrous sulfate, usually for 4 to 6 weeks. It is our drug of choice. It helps improve the red blood cell formation and replace our iron stores. Definitely look over box 44.5 about nursing responsibility for ferrous sulfate. We also want to encourage the diet of the child to be rich in iron and vitamin C. Why would vitamin C make a difference? Well, that enhances the iron absorption. We want to allow for frequent rest periods. And we need to do a lot of nutritional education and counseling. Breast milk is a poor source of iron after 5 months of age, which is also the time that we start incorporating solid food into their diet. Infants who are younger than 12 months should be on a formula formula or breast milk until around 12 months of age. And then we're moving to whole milk, but we know that whole milk does not give us a good source of iron. So toddlers who are 12 months or older decrease the intake of milk, so no more than 1 quart, or again the 32 ounces per day. Sometimes give the milk after a meal, so they're not filling up on the milk and they're eating their solid foods. You give them the milk after the meal, making sure that we're introducing solid foods at an appropriate time. For children, again, we can use the types of foods: iron-rich, iron-fortified cereals. Walk down any cereal aisle, look how much all these cereals are fortified with different vitamins and minerals, iron. That's because that's how we can get it incorporated into food. Also thinking about meats, green leafy vegetables that are higher in iron. With teenagers, again, a good diet, but reducing the amount of junk food that they're eating, because we know that junk food doesn't have a higher iron, I shouldn't say intake, but a high iron concentration in it. And cow's milk contains substances that bind with iron and interfere with absorption. So when you're giving an iron supplement, it should not be administered with milk or milk products, because it will not be absorbed as well. When you are giving that iron supplement, again, review that box. What kind of things do you want to give it with if you can't give it with milk? Well, one of the best things you can give it with is vitamin C drinks, so like orange juice, right? Because the citric acid helps with absorption. You got to think about when's the right time of day when you're educating parents. When's the right time of day to give it? Do you give it with meals, or do you give it on an empty stomach? If they're taking, especially young kids who can't swallow a tablet, and you're giving them liquid, what do they need to do? That iron liquid supplement is staining to the teeth, so they need to be making sure they're either taking it through a straw, they're brushing their teeth afterwards to try and prevent the staining of their teeth. So again, look over that box, because it's going to give you a lot of the nursing education things to teach a family. All right, let's move into your hematologic disorders. And the first one we're going to talk about is sickle cell anemia. The etiology and patho for sickle cell anemia: it is an autosomal recessive inherited disorder that is carried on the beta chain of the hemoglobin. So both parents have to have trait in order for their offspring to have disease. And for each pregnancy, it's the same chances of their child having disease. So for both parents to have trait, both parents must have trait for child to have disease. So they have a 1 in 4 chance that their child will have disease. There's a 50% chance that their child will just have trait and they will not have any signs of disease. And a 25% chance, or 1 in 4 chance, that their child will not have disease and will not have trait. It occurs in about 1 out of every 400 African American infants in the U.S., so pretty frequently. And what happens with sickle cell anemia? Those erythrocytes become characteristically elongated and crescent shaped or sickled, which submits them to low oxygen tension, low blood pH, which puts them more acidotic, and increases their blood viscosity, which occurs with dehydration or hypoxemia. Or hypoxia, I should say. When those red blood cells sickle, or they change to that elongated shape, they can't move as freely anymore through those vessels, which in the next slide will show you, or the next 2 slides will show you the shape, and then show you an example of how they don't move as freely. Because when they're in that elongated shape, they're not as flexible to move through all the bends of our veins and our arteries. So they just don't move as freely, which leads them to stasis and further sickling, which is where we get into sickle cell crisis. So I'll talk about it in 2 slides again, where there's got that visual of the elongated shapes and moving through blood vessels. This slide is just showing normal red blood cells versus the sickled ones, or the elongated ones. You can see when they're in that kind of crescent shape, they're definitely much more rigid. They're harder they're not as flexible, they don't move as freely as they would if they were the circular shape, or that way they can kind of bend and flex and move as they normally would. again, this slide's just showing when they become elongated, how much more easily it is for them to cause a blockage and get the child into sickle cell crisis. When they have that blockage, it creates basically the blood flow halts, which then the distal to that blockage becomes ischemic, and it results in acute pain and cell destruction. So ideally, we want to prevent that. Right? Let's also talk about diagnosis. In diagnosis, we can diagnose them prenatally with sickle cell. We can do that by chorionic villi sampling. We can do cord blood during amniocentesis as well. If it's not done prenatally, every newborn is screened at birth if the tests were not previously done. But it is just a screening tool, right? It doesn't tell them if they have trait or if they have disease. So what they do is called a Cyclodex. It's the sickle solubility test, and it's a screening tool again that can detect if there is hemoglobin S present. But again, it cannot differentiate between trait and disease. In order to get a definitive diagnosis if they have sickle cell anemia, they need to have hemoglobin electrophoresis done, which then separates the various forms of hemoglobin and gives you the definitive diagnosis of sickle cell disease. We always encourage genetic testing as well to help identify carriers and children who may have disease. And especially as those children who do have disease, or even if they have trait, making sure that they are aware so when they become older and they find a partner, someone that they're with, what their chances of passing that trait on, especially if their partner has the trait as well. Let's talk about sickle cell crisis. Sickle cell crisis denotes a sudden and severe onset of sickling. And what happens is you have pooling of these newly sickled cells in the blood vessels, which then leads to the tissue hypoxemia beyond that blockage, or what we also refer to as vaso-occlusive crisis. That is the main one that we're going to focus on and what I want you to study for testing purposes, because this is the most common sickle cell crisis that occurs, is the vaso-occlusive crisis. They're most apt to a sickle cell crisis when the child has a gastrointestinal illness, which leads to dehydration, because dehydration can cause sickling. They have a respiratory infection, which results in the lowered oxygen exchange and lowered arterial oxygen levels. They're also with extreme strenuous exercise, which can lead to tissue hypoxia. They're more apt to have those sickling crises. The symptoms are sudden and severe, and they are painful. When we look at their labs, their hemoglobin level is usually between 6 and 8 grams per 100 ml, so definitely low. If we did a peripheral blood smear for lab work, we would see sickled cells as well. And then their bilirubin and their reticulocyte levels will be increased. Why would those be increased? Well, that's because of the red blood cells being damaged, as we tend to see those go up. Their white blood cell count can be elevated as well. There are other types of crisis that can occur. There's sequestration, aplastic crisis, hyperhemolytic crisis, and megablastic crisis. But for the purposes of test, I want you to focus on the vaso-occlusive, which is the remainder of what your notes are going to focus on, especially when we get to the therapeutic management of sickle cell crisis. So focus on the vaso-occlusive, because it is the most common occurring crisis that we see. Right. The assessment for sickle cell anemia. Again, it can be diagnosed at birth because of the required blood spot screening, or part of that newborn screening. And then at approximately 6 months of age, they will begin to show initial signs of fever and anemia, and the stasis of blood and infarction may occur in any body part, which leads to the local pain. As the child grows, they tend to have slight, thin build, characteristically long arms and legs, and they'll have a protruding abdomen due to the enlarged spleen and liver. In adolescents, their spleen may actually decrease in size because of repeated infarction and atrophy, and which leaves the teenager more susceptible to infection because the spleen can no longer filter the bacteria like it's supposed to. So oftentimes they're going to need prophylactic antibiotics, and making sure we keep up with their age-appropriate vaccines to prevent infection. They can also have acute chest syndrome, which begins to occur and it leads to pneumonia. And it develops because the areas of the lung become inflamed and hypoxic. And those sickled cells like to adhere to the irritated epithelium, and then they fail to be reoxygenated. So blood transfusions are used oftentimes to increase the oxygen carrying capacity of blood. They'll also need to be put on a broad spectrum antibiotic to resolve their pneumonia. And if you think about it, the symptoms go right along with pneumonia: fever, tachypnea, wheezing, and a cough. We can see some other changes as well. You're going to see stasis of blood flow because of the cirrhosis of the liver. The kidneys can have subsequent scarring, which leads to decreased kidney function. The eye sclera are yellowed because of bilirubin from the destruction of the sickled cells. Their small retinal occlusions leads to decreased vision, and oftentimes we see, especially in males, the priapism, which is caused by the vasoocclusion in the penis. Let's talk about the therapeutic management needed for a child with sickle cell anemia. There are 3 primary needs, and not in any particular order, but the 3 primary needs are pain relief, adequate hydration, and oxygenation. For pain relief, the book talks about giving Tylenol or acetaminophen could be adequate for some children. In my experience, that is not always the case. They oftentimes, when they're in those sickle cell or vaso-occlusive crisis, they often do need, at least in the beginning, narcotic analgesics, such as IV morphine. And what that does is allows the child, they're maybe not completely pain-free, but decreased pain to where they can tolerate it. They're able to relax. And when they're able to relax and their pain is decreased, then it leads to a decrease in the metabolic demand for oxygen, which then further decreases the sickling, and sickling begins to end. So it's really important to maintain their pain, believe what the patient or the child says their pain is. They are often notoriously kind of under-medicated, and that's just because they tend to have higher pain tolerance. This is something that they deal with vaso-occlusive crisis. They can be in vaso-occlusive crisis for days, and sometimes they're in crisis for quite a while before they even seek treatment. And usually by the time they seek treatment, they are just miserable. So pain management's really important with these kids. They tend to be kind of called clock watchers, that they're always, they want their pain meds right when it's due. Well, if you were in extreme pain for days on end, you probably would be too. So believe what they say. It's always important to make sure you're charting exactly what they say their pain is, and that we're doing frequent assessments. And it's not just about, when you think about pain management, it is not just about pharmacologic management. There's a lot that can also be done non-pharmacologic that can help them. So you got to think about those things as well. The second primary need, adequate hydration. Oftentimes they need IV fluid replacement, and again, that's to help because of the acidosis that's occurring from the tissue hypoxia. It's going to help correct it needs to be corrected. The acidosis needs to be corrected, and of course looking at electrolyte replacement as well. You would never administer potassium through an IV until you have confirmed kidney function. How do we confirm kidney function? Just simply the child voiding, because we want to make sure that everything is functioning like it should. Otherwise, if they don't have good kidney function and we're giving them potassium, then we get into cardiac issues. All right, and the last one, we want to give them oxygen. And the oxygen isn't necessarily about, yes, it may help their O2 level, but it's really about helping to prevent further sickling. So it just depends. They could have an okay PO2 level, like on a pulse ox, but oftentimes we can give them a little bit of supplemental oxygen, and that's just trying to prevent further sickling. So again, there's not any one particular order. All 3 of these are very important things that they need in order to manage their sickle cell crisis. Other treatment measures that can be done We can look at blood transfusions, and usually we'll give them packed red blood cells. And again, this can also be necessary to prevent those life-threatening complications. It can help them maintain hemoglobin above 12. But understand that the blood transfusion that they get, the packed red blood cells that they get, those packed red blood cells that they get are someone else's. So therefore, those red blood cells aren't going to sickle, but their own red blood cells can still sickle. So giving a blood transfusion can do several different things. It helps because then they've got red blood cells that won't sickle, but their own red blood cells will. It helps to dilute the amount of sickled bloods in their system in the sense of circulatory, so they don't have as many issues with circulation, which then gets them into the ischemia. It helps with oxygen carrying capacity because they've got red blood cells that aren't going to be sickled. So really important to think about when you're doing blood transfusions. There's lots of effects that it has, and I'm not going to go through it, but the next two slides also talk a little bit about blood transfusion administration and, of course, signs and symptoms to look for if there's a reaction. Another treatment measure could be hydroxyurea, which is an anti-neoplastic agent, and it has the potential to increase the strength and oxygen carrying capacity of these sickled cells. It's typically given orally. However, the side effect is anorexia, so it is important to make sure that they're monitoring good nutrition intake. And kind of a last resort, and you're not going to be tested on this, but if the other measures aren't effective, we can look at doing exchange transfusion. We can also look at doing stem cell transplant, but those are not our first lines of management that we do. And the last thing I want to talk about is the nursing care management for a child with sickle cell. It's really important to monitor their growth and watching for failure to thrive. So those growth charts are really important. We need to be doing a careful multi-system assessment because that sickle cell crisis can occur anywhere in the body. The sickling can happen in any extremity, pretty much any body part, and affect it. So it's really important to do that multi-system assessment. We need to be assessing their pain at a minimum of every 2 hours and as needed. And again, with pain prevention, I kind of talked about this. They tend to be under-medicated, noted as clock watching. Heat can be very soothing because heat does what? Vasodilates. Or cold just enhances sickling and vasoconstriction, and we don't want that. We need to be monitoring eyes and nose. Again, thinking about they can easily become dehydrated in hot weather, depending on what climate they live in or if they're doing strenuous activity. And we know that dehydration can lead to precipitating a sickle cell crisis. So important to maintain good eyes and nose, making sure we're giving plenty of oral and if they're in the hospital, IV fluids. We want to encourage passive range of motion to prevent venous stasis. And we want to observe for presence of inflammation or possible infection and having them seek early intervention for problems, especially if there's a fever greater than 101.5, and giving antibiotics as ordered as well. With the oxygen, we talked about oxygenation being important to prevent further sickling. Prolonged oxygen can actually aggravate the anemia, so we only want to use it for a short term amount of time. We try and use it only for what we need. And when you think about parent teaching, again, the importance of adequate hydration to prevent the sickling, because we know, again, hydration will precipitate or can precipitate a sickling crisis. Again, reporting signs of fever, 101, acute chest syndrome, again, the early signs of pneumonia, so that we can get treatment started sooner rather than later and prevent the amount of sickling that occurs. We want to also teach them to make sure they're avoiding low oxygen environments, so like high altitudes or non-pressurized airplanes, and the importance of doing pneumococcal and Hib vaccines, again, to prevent infections. All right, hemophilias. They are inherited disorders of blood coagulation, and there are numerous types, And each one involves a deficiency of a different type of blood coagulation factor. For testing purposes, I want you to mostly focus on hemophilia A, because that is the primary one that we see most commonly. There are a couple other ones that I will touch base on, but we're mostly going to focus on hemophilia A, which is your classic hemophilia, and it is deficiency of factor 8. Deficiency of factor 8. Its etiology, it is a sex-linked recessive trait, and it occurs in 1 in 5,000 white males. It only occurs in white males. Females can be carriers. So they have significantly lowered but sufficient levels of factor 8, and it does not manifest as a bleeding disorder. However, because females are carrier, they can pass it on to any children. The baseline level of factor determines the occurrence of bleeding episodes, so it can range from mild to severe. Your pathophysiology. Factor 8 is an intrinsic factor of coagulation. Its absence causes the intrinsic system that manufactures thromboplastin to be incomplete. So the child's coagulation ability is not totally absent. It's because of the extrinsic or the tissue system remains intact. The child's blood will eventually coagulate after an injury, but again, depending on how deficient they are, depends on how long their bleeding episodes and how severe those bleeding episodes can be. The assessment for hemophilia. It is often recognized first in an infant who bleeds excessively after circumcision. So remember, again, this occurs in males. So usually after a circumcision. And because the infants don't receive too many injuries, children's bleeding tendencies may not become apparent until they become active. So they start crawling, they're climbing, they're walking, those kind of things. Because, when your infant is immobile, no, I shouldn't say immobile, but they're, developmentally, they're not very mobile, they're not as prone to having bleeding tendencies. Suddenly, lower extremities, though, become heavily bruised as they start to become more active, easily bruised compared to normal, and they often have soft tissue bleeding and painful hemorrhage into joints, which is called hemarthrosis, and we'll talk a little bit more about that in just a little bit. Those joints become swollen and warm. They can also have severe bleeding that occurs into the gastrointestinal tract, the peritoneal cavity, central nervous system. So it can occur anywhere in their body. And then looking at kind of this little picture that I have, kind of an overview of hemophilia A, just in the general sense. It's not really a lot about, it does have some signs and symptoms, but not as much. It just kind of gives you a general idea of what we do for a child with hemophilia. This picture is just showing you what hemarthrosis or bleeding into the joint looks like. They can have repeated bleeding into those joints, and with repeated bleeding it causes damage to the synovial membrane, which can result in loss of joint mobility. So anytime when you think about bleeding into the joint, it becomes swollen, it's painful, there's a lot of heat. Again, over time, it can kind of do damage to that joint and limit their mobility long term. When you think about therapeutic management, a child who, if they're deficient in factor 8 because of having hemophilia A, they're deficient in factor 8, then our therapeutic management is aimed at the administration of giving them enough factor. So administration of factor 8. That can be done either through fresh whole blood, fresh or frozen plasma, or just simply giving them a concentrate of factor 8. The concentrate is supplied in a powdered form. It can be stored at home, and then the child or the family is taught how to reconstitute that and give it as well. For some children, though, we can also give them the administration of desmopressin, or what's called DDAVP. And what that does, it actually stimulates the release of factor 8 in order to help prevent bleeding episodes from occurring, which is what I like about this graphic that I have up here. Not just about DDAVP, but when you have a child who has factor 8 and they're have a lack of the amount of factor for clotting, what it looks like without replacement therapy versus what it looks like if you give them the amount of factor that they're deficient in. This child doesn't bleed more, they just bleed for longer periods. So when you think about diagnostics in the sense of like if you did their, which I totally skipped over, sorry, but if backing up, doing diagnostics, when you look at their history and their laboratory test, their labs especially, their PTT, or their partial thromboplastin time, will be low because it reveals low levels of factor VIII, which means they have prolonged bleeding. They will have a normal platelet count and prothrombin time, or PT time. So it's just their PTT time that is prolonged, and again, it's because they have insufficient amount of factor VIII, so they don't bleed more, they're just bleeding for longer periods of time. When you think about the nursing care for a child who has hemophilia or factor VIII deficiency or classic hemophilia, we want to teach parents to make sure they have close supervision in a safe environment. No, that doesn't mean you wrap them up in a bubble and they're not allowed to do anything. They still have to be kids, right? And then again, thinking about as they age, they should only be shaving, boys when they start shaving should only be shaving with an electric razor versus like a manual razor, like a handheld razor. Or I shouldn't say handheld, that's poor, because even an electric razor is handheld. But they should not be using a manual razor, and that's because with a manual razor, they tend to have more nicks and cuts, which then puts them at risk for the bleeding. With an electric razor, that is decreased. Pretty much extinct. I'll get my words out, because you can't cut yourself with an electric razor. For superficial bleeding episodes, we want to apply pressure for at least 15 minutes and ice, because ice is going to do what? It's going to vasoconstrict, which means when it vasoconstricts, we stop the amount of time that they are bleeding for. We want to replace the factor as ordered by the physician. We want to maintain joint integrity during acute phases. So usually we use the immobilization, elevation, and ice as a way to maintain joint integrity. We still want to provide for those opportunities for normal growth and development. Like I said, they still got to be a normal kid. They still got to do activities. You can't keep them inside wrapped up in a bubble. We want to substitute the subcutaneous route anytime that we can when possible, instead of doing IM injection, because even with immunizations and shots, they can still bleed even from those types of medical procedures. And managing the hemoarthrosis, the bleeding into the joints, again, we want to elevate and immobilize that joint during the bleeding episodes, use ice, analgesics, do range of motion after the bleeding stops to prevent contractures, and we want to avoid obesity to minimize the joint stress that they have. When you think about teaching, we need to do a lot of bit of teaching with the family and the child. Early recognition of a bleeding episode, and then how to administer factor replacement therapy are certainly important components. And again, the child and the parent can be taught at home how to reconstitute and administer replacement therapy or replacement factor. A child at about the age of 10 can be taught this. Prior to that, it's really kind of the responsibility of the parent. But they can be taught to reconstitute and then intravenously give them the factor to prevent the bleeding immediately after an injury. We also use a combination of pressure applied to the bleeding site, immobilization of the injured extremity, ice packs locally, and almost always we are trying to eliminate the need for hospitalization. But the child still may need to be assessed by a healthcare provider. A child who does have hemophilia needs to be wearing a medical identification bracelet or necklace, some sort of medical identification, and older children are encouraged to be able to recognize the situation and disclose their condition when it's important, especially during like dental extractions or injections. And you got to think about safety. Again, they still got to be kids, so making sure they're using protective equipment such as padding and helmets probably better that they're in a non-contact sport than a contact sport. So finding alternative sports for them to do. Swimming, walking, jogging, tennis, golf, fishing, bowling are all encouraged. Probably not football or soccer where it's a contact or more of a contact sport. We don't want them taking any aspirin or any aspirin-containing compound. Acetaminophen is usually a suitable substitute to help manage their pain at home. Because we know, why don't we want them having aspirin? We know that aspirin is a blood thinner. All right, the last two disorders we're going to talk about in hematologic disorders is von Willebrand disease and hemophilia B. Von Willebrand disease is an inherited autosomal dominant disorder, which means it occurs in males and females, most frequently in Caucasian, and it is a factor 8, so that we're deficient in factor 8, and we have an inability of the platelets to aggregate, and the blood vessels constrict to aid in coagulation. So again, our bleeding time is prolonged. What makes this different from classic hemophilia or factor 8 is the fact that, one, it affects both males and females, and it's not only deficient in factor 8, but also deficient in the ability of the platelets to aggregate the blood for coagulation. So your clinical manifestations, most hemorrhages tend to occur from the mucous membrane sites. Epistaxis is the major problem that we see in children because they tend to rub and pick at their noses. Especially in girls and women, menstrual flow is usually unusually heavy, I should say, and childbirth puts them at an obvious risk as well. Our therapeutic management for von Willebrand disease is we want to control the bleeding with factor 8 replenishment, and we can use DDAVP to stimulate the factor 8 release that they do have. And then hemophilia B is also known as Christmas disease, and that's because it was first noted in a patient by the name of Stephen Christmas. It is a sex-linked recessive trait, and it is caused by a deficiency of factor 9. Factor 9. It accounts for about 15% of cases of hemophilia. Our treatment for deficient in factor 9, we want to give them factor 9 concentrate. And again, just like factor 8, it is available for home administration. So again, you would do all the teaching surrounding how to reconstitute and administer factor 9.